Welcome to the seminar series for the Center for Digital Transformation of Health at the University of Melbourne. I'm Wendy Chapman, I'm the director of the center, and we are very happy today to welcome Dr. Jason Adelman. Jason plays he plays many roles and wears many hats as the Chief Patient Safety Officer at New York Presbyterian, but also has really forged out a research career to bring together the operations and the research in this, creating a safety culture. And we really look forward to hearing about your experience, Jason. Thanks for being with us.
All right, terrific. Thank you for having me. So let me share my slides. Can you see my presentation?
Yes.
All right. Well, I'm honored to be here, and it's exciting for me to get to present around the world. It's 8 p.m. on Wednesday where I am in New York, and I understand it's Thursday morning by you. Tomorrow Thursday at 10 a.m. I'll be thinking what you all are doing after I go to sleep and wake up. I am, as Wendy said, I balance operations and research. I'm the Chief Patient Safety Officer, and that means I oversee quality and safety for a large part of New York Presbyterian, which is one of the top 10 US health systems. I'm also a researcher, and I'm funded by the NIH and AHRQ. And I'm going to share some of my research today, specifically on this problem of providers placing orders on the wrong patient. So I have no financial disclosures. That's my large family there. I'm going to start by sharing a case. This is a real case that happened. Mrs. X, an 89-year-old female with a history of diabetes, hypothyroidism, was admitted to a telemetry unit with a diagnosis of rapid atrial fibrillation. The day after Mrs. X was admitted, a medicine resident of PGY1, a first year, accidentally placed an order for methadone, 80 milligrams for Mrs. X, which he meant to order for another patient. For those who don't know what methadone is that very powerful narcotic that we give to heroin addicts to try to help them get off heroin. And so we gave this significant dose of methadone to an elderly female instead of the young heroin addict. Both patients were on the resident's list in the electronic health record. A pharmacist signed off on the methadone order, and later that day, a nurse in training administered the medication. Several hours later, Mrs. X was observed to be restless and complained of being hot and nauseated. And shortly thereafter, she was found unresponsive, pulseless, with blue extremities. A code was called, she was intubated and transferred to the medical ICU. This case actually launched my career as a patient safety researcher with a focus on wrong patient errors. And let me get in a little further here with you. So first of all, I love this slide. I somehow happened upon this. I don't know if you could see there. This is from the Gazette of Health in London, and that year is 1820. So we've been struggling with wrong patient errors for 200 years. So in the Gazette of Health, it said, having another patient of the same name in the hospital whose complaint was violent spasms and flatulence of the stomach, the prussic acid was by mistake administered to the wrong patient, a circumstance highly creditable to the apothecary and by no means uncommon in London hospitals. I actually had the privilege a couple of months ago of giving a similar talk to a bunch of health leaders in London, and I got to share this slide, and then everybody asked me for this slide after my talk. So, but 200 years we've been struggling with this issue of wrong patient errors. Now, before my research, I looked to see how often people would report wrong patient errors. Like in a given hospital, what's the average number of times somebody placed an order on the wrong patient, and we captured that. And so this, there used to be this medication reporting system in the US called MedMarks. And this is a summary of 120 facilities. And they reported an average of 9 wrong patient errors a year, specifically in a electronic ordering system, a CPOE system, so an average of 9. And the early research from Joe Nash and others about, there was talk about this problem of, in this new world of electronic health records, people placing orders on the wrong patient. And the researchers have been saying for some time, the leading theory as to why someone placed an order on the wrong patient was juxtaposition errors. That's what they call them, where 2 patients are on the same hot list, like the story I just told you, and the provider means to click on one patient, but inadvertently clicks on the one just above or below, juxtaposed to the one you're looking for. That's where the team, and juxtaposition errors, they're responsible for wrong patient errors, but also they thought wrong drug errors and other types of errors. Now, when that error happened, Mrs. X, and I'm the patient safety officer at the time, wearing my operations hat, I was working with others to brainstorm on interventions to try to prevent wrong patient errors. And in our conversations, our conversation turned to, there were all these different ideas, but how are we going to know if this even works? A lot of the ideas were quite intrusive. Every time someone wants to place an order, fire off an alert saying, are you sure you want to place orders on Hermione Granger, 15-year-old, and other such ideas? And how are we going to know if we're doing anything? And so we came up with this idea of an automated measure that could capture wrong patient errors that we could use as an outcome measure to trial an intervention. And it started just, again, in my operations role, we just wanted to really make sure that what we're doing was working. So the automated measure we developed proved to be very effective. And this is a schematic of how it works. Imagine I, as a doctor, I place a couple of orders for patient A, as you see there. Let's say ciprofloxacin, an antibiotic, a left hip x-ray, and a indwelling urinary catheter. So sort of 3 specific orders. And within a few minutes of placing those orders, I cancel them. And then the same doctor, immediately orders the exact same ciprofloxacin, left hip x-ray, and indwelling urinary catheter on patient B. The original programmer I used to work with called it the oops query, like, oops, I'm on the wrong patient. Let me cancel that and fix that. So we built the measure, and it turned out we decided instead, at first I called it the oops query, named after what my programmer had said, but we decided to give it a more professional sounding term. So we call it the retract and reorder measure. And it turns out that across our hospital, there were 6,885 retract and reorder events in 1 year. And so we wanted to know, is this real? Could this possibly be that many? So we set up this machine. I call it a machine. It's not really a machine, but this system that would query the production electronic record every 30 minutes and look for a retract and reorder event, would send an email to a research assistant that was on my team, and they would call the provider within 45 minutes of a retract and reorder event, and in a very respectful way with IRB approval, would say, excuse me, Dr. So-and-so, do you mind if I ask you questions? I'm working with Dr. Adelman, the safety officer. We have IRB approval, it's voluntary. Everything will be anonymous. But when you placed those orders on Mrs. A and then canceled them and placed it on Mrs. B, was that a wrong patient error? And that was our system. We called 236 people, and 170 confirmed it was a wrong patient error, 76.2%. And so if you translate that to the 6,885 events, that translates to over 5,000 a year. 14 patients a day have, for some amount of time, some order that's live, that's placed for them, that's really meant for another patient. Now, these are all self-caught events, so the provider, sort of by the grace of God, would catch themselves and realize, oh gosh, I'm on the wrong patient, and fix it. And in 1 year, 1 out of 6 providers placed an order on the wrong patient, and 1 out of every 37 patients admitted to the hospital had, at least for a short amount of time, orders placed for them that was meant for another patient. And when I say 1 out of 6 providers placed an order on the wrong patient, when we go past 1 year and look at a couple of years, pretty much everybody has done it. Certainly all the residents and high order providers. So you remember I told you this MedMarks database had a mean of 9 wrong patient errors in 1 year. We had 5,246. And the significance of everything I shared with you so far is multifold. First of all, we have the ability to call people in real time and ask them why they made the errors. The researchers before us, they couldn't do this. They would, the original reason they came up with juxtaposition errors is Joe Nash and others would get a bunch of residents and hospice attendings in a room and talk about the issue and ask them why they thought they made wrong patient errors. And someone might remember something that they did 3 months ago, 4 months ago. But we have the ability to talk to people 30, 40 minutes after they make an error. And so that was very powerful. And we learned a lot about errors, which I'll share with you, about why they make errors. But also, this is a very reliable measure. It's not voluntary reporting. So there's no reporting bias, like, you know, it was only average of 9 when people report it. So sometimes people don't want to admit their errors and don't want to report it. It doesn't require chart review. Chart review, if you were going to do a project on wrong patient orders and use chart review as your means to measure the effectiveness, first of all, it's a massive effort. And second of all, it's still hard to determine if somebody ordered a simple blood test on the wrong patient. They're not going to write that in the chart. It would be hard to even figure it out because we order simple blood counts for all our patients, really. But this is an accurate measure. We can tell you how many happen during the day, during the night, at weekends, made by residents, made by attendings, made in the ICU, made in the ER. We can quantitatively describe quite accurately how many errors happen. Now they're near misses, they're self-caught. And so, but we generally believe, as the patient safety world does, that the value of near miss errors are they have the same causal pathway as the errors that cause harm. The difference between Mrs. X that got the methadone order that was meant for the young heroin addict and any of these patients is, as I said, by the grace of God, people realize, oh my goodness, I'm on the wrong patient. And when they don't realize it, that's when bad things happen. Now, if it's a simple blood test or Tylenol, nobody may be the wires or no one's going to report it. It's only when it's a really toxic sort of test or order like methadone where you can't help but own it and deal with it, which is what happened in this case. So I told you, Joe Nash, juxtaposition error. That was the leading theory. 2 names juxtaposed. Well, it turns out when we called those 230 some odd people and 76% confirmed it was a wrong patient error, only 10% said juxtaposition was the mechanism. 80% said it was something else. 80% had another reason. It was interruptions. That was the main cause, not juxtaposition. It was the same story we heard over and over again. I'm admitting Mrs. A, ordering all of her orders for a new admission, her diet, her exercise, her lab tests, her imaging tests, her medications. Somewhere in the midst of all these orders, I get a call that I'm admitting Mrs. A, and I get a call that Mrs. B has pain. Can I order Percocet? So I quickly go over to Mrs. B. I order the Percocet, heading back to finish Mrs. A's admission, and I get interrupted. I have a 5-minute conversation with the nurse about some other patient, and then I go back to finishing the admission, but I never toggled back. So I was just on Mrs. B for a moment, just to order that one med, and now the rest of the admission orders go on Mrs. A. We heard some version of that story over and over again. Interruptions. This measure, the retract and reorder measure, in the United States, before any measure becomes part of a public reporting program or in a pay for performance program. It's endorsed by NQF, the National Quality Forum. So CAUTIES and CLABSIs and all sorts of things. The Wrong-Patient Retract-and-Reorder measure is the first health IT safety measure endorsed by NQF. So now that we had this automated measure, we started using it to test different research questions. The first thing I don't have a slide here on it, but the first thing we did is we tested a simple pop-up alert versus a more intrusive intervention. The pop-up alert, just before you place an order, you said, as I said before, are you sure you want to place an order on Hermione Granger, 16-year-old female in the CCU? And you just hit OK and move on. And we had this more intrusive intervention where you had to type in the initials, age, and gender. So for Hermione Granger, it would be HG 16 for 16-year-old and F. And we did a randomized trial where a third of our patients, this is after Mrs. X, this methadone error. This was an unfunded study just to honestly test interventions. We had different ideas out there. About 50% of my colleagues liked the pop-up alert and wanted to try that. But the other 50% thought people are just going to blow by it. And they liked that more intrusive. You had to type in the initials, age, and gender. But the people that favored the pop-up alert said that's too intrusive. And so what we did was we randomized providers into one of three groups. A third, we didn't change the system at all. A third got the pop-up, and a third got that more intrusive intervention. And compared to control, the pop-up alert reduced wrong patient errors as measured by the retract-and-reorder measure by 16%. And the more intrusive intervention, typing in initials, age, and gender, reduced them by 41%. And so that's what we turned on for the hospital, the more intrusive intervention. So then I applied for my very first grant to study a research question that once I published a paper on the automated measure of wrong patient errors in my randomized trial, the pop-up versus the more intrusive intervention, lots of people in the US were reaching out to me about wrong patient errors, why they happen. And a lot of people were concerned about this. This is a sort of an older picture of Epic that shows 4 records are open at the same time, like 4 tabs in a browser, an internet browser. And people thought that this could lead to wrong patient errors and that EHRs should restrict hospitals to just one EHR, one record open at a time. And I wanted to get my first grant. Ever since I developed the wrong patient error measure, I knew I started it because of a real operations error, but I knew there was something special about it, like all these errors. There was a lot of them, and we had enough power with over 5,000 errors, we had enough power to test interventions. You couldn't do it when you only had voluntary reported 9 errors a year. You wouldn't have enough power, and they're not reliable anyway. But this automated measure with thousands of errors that was reliable, we could test interventions. So my first one was the unfunded one to address the Mrs. X error. But then people were reaching out to me about this. So I wanted to study this. And to help me get the grant, I did a national survey in the US where I asked chief medical information officers and CIOs, chief information officers, how many records do you allow open? How many records does your EHR allow open? How many do you choose to allow open, and why? And so many of the EHRs allow multiple records open, Cerner, Epic. And interestingly, about 40%, or it says 42% there, allowed the maximum open. Whatever the system maximum was, that's what they allowed. Unrestricted, we called it. But almost an identical number of 41% restricted to 1. I mean, it's really like cut 50-50. And then 18% hedged, I call it hedged on like 2, where, and they would literally say when they explain, those that allowed unrestricted said, providers need to be able to multitask. There's a lot of, we deal with a lot of patients at the same time in the ER and the ICU on the floors, and we have to be able to move quickly between patients. But so that was the 42%. The 41%, what they wrote in their explanation is they're really afraid of wrong patient errors. Many of them had wrong patient errors, and they thought they were due to having multiple records open. So they restricted to one. And those that hedged at two literally said, we want to find a balance between, we know providers have to multitask to be efficient, but we're concerned about wrong patient errors. So we sort of split the baby and are going with two. And this is what we found, but man, was it like the perfect setup for a research question for a grant. So I submitted this to AHRQ as a smaller grant, and we proposed randomizing providers in EPIC to half the providers were allowed the maximum that EPIC allows for records open, or workspaces they call them. And the other half of the providers were restricted to just one. And so we did an honest randomized trial. Now, I should mention that in the United States, there's a part of the US government called the Office of the National Coordinator, they call it ONC, and they're the ones behind meaningful use. In the US, they give financial incentives to adopt EHRs, and they have a national recommendation to limit to just one. And then the Joint Commission copied that, and so they also say what Joint Commission regulates hospitals here, I think maybe in Australia as well. But it's all expert opinion, no evidence at all. And so my goal was do a study, randomize. I thankfully got the grant, got funded. It was published in JAMA, and these are the results. If you look at the overall, the wrong patient error rate was 90.7 in restricted and 88 in the unrestricted, virtually the same. The odds ratio is 1.03, ranging from 0.9 to 1.2. The p-value was 0.6. Interestingly, in the emergency room, where providers really use the multi-records a lot, they multitask more than any other place we found, and where's the largest concern. If you see there, the odds ratio was 1.00. The p was 0.96. So in all the environments we tested, inpatient, outpatient, peds, critical care, obstetrics, no meaningful difference. And so we were able to show that it's not having 4 records open that's the problem. It really seems to be the same thing I told you from the start. It's interruptions. It doesn't matter. The original error, Mrs. X, was in an older EHR made by General Electric, GE, called CareCast. And that system only allowed 1 record open at a time. But that same story of admitting 1 patient and then toggling to another one, it doesn't seem to matter if you are restricted to 1 or have multiple records open. It's the act of being interrupted where you forget what you're doing. Like we sometimes don't, our working memory sometimes fails us. We think we're gonna remember what we're doing, and then 5 minutes goes by and we just forget. And whether you have 1 record open or multiple records open, the same interruption mechanism causes wrong patient errors. So I got another grant from AHRQ to study if photos could prevent a wrong patient error. And so we're doing this in EPIC. This is a collaboration between New York Presbyterian and Johns Hopkins. And in EPIC, you can actually display photos in 2 different places. If you see, there's a little circle in the corner there with a GK for Grace Kelly. That's on the storyboard, and you could display a photo in that circle. And you can also display a photo in a pop-up. And so we're doing a 4-arm randomized trial between Columbia, Cornell, which are the 2 New York Presbyterian hospitals, and Johns Hopkins, where 25% of the providers will get the photo just in the pop-up, like you see here. 25% will get it just in the little circle. 25% will get both, and 25% will get a control, nothing. And so we'll be able to see, do photos help? But not only that, does it work? Do we need it in a pop-up? Can we get away with it being just in the corner? Is this additive by having both? And so we'll really be able to, we have a lot of power to assess this question and try it in different environments. And so we're just getting started with the study, but I'm excited. Another issue that came to my attention was in the neonatal ICU, when babies are born prematurely and they weigh 2-3 pounds and they have to be admitted to the NICU sometimes for months. In the US, they were often named baby boy or baby girl. This is a screenshot from the EHR. Baby boy Jones, baby boy Johnson, baby boy Jackson. And you could see how that could be a risk for wrong patient error. They basically lose the distinction of a first name. And so we wanted to evaluate this question and test if we could use a more distinct name. At first, I wanted to call the kids like Cutie Pie, Buggy Bear, like give them cute names, because I was worried about twins. But the head of neonatology said, that's a great idea, Jason, but you can't do it. You can't name children for them. So instead, we compromised and we said, let's use the mother's first name. If you could see there, Linda's girl, Melanie's boy, Catherine's boy. And so we made this change to add more distinction. And we showed that just the simple change led to a 36% reduction in wrong patient errors. Published this in Pediatrics. Pediatrics is the journal of the American Academy of Pediatrics. It's one of the leading journals in the US. And at the American Academy of Pediatric Conference, the editor-in-chief of Pediatrics highlighted this as one of the 10 best articles of the year or most impactful articles of the year and said, how often do you see an intervention that's as simple as this? If you see the little box there, baby girl Jackson, baby girl Johnson, baby girl Jones, and changing to Wendy, Brendan, Catherine, and it being so effective in something as important as wrong patient errors. And so the Joint Commission now made this a regulation. You can no longer have baby boy, baby girl. You need some distinct naming convention. So I was very proud that I did research that led to a national recommendation, but what's been sitting with me is this, that even if you use our more distinct naming convention, like you see here, Judy's boy 1 Johnson, Judy's boy 2 Johnson, medical record numbers are often given out sequentially. So you see the medical record numbers are identical except for one numbers, the name are identical except for one character. For twins, these are twins. And in my hospital, Columbia, 30% of the kids in the NICU are twins or triplets. And so I wanted to assess, I felt like I didn't completely solve the problem and I wanted to check. So we did a study. This was published in JAMA Pediatrics. And we looked at what's the wrong patient error rate for singletons. And you could see 3.8% of singletons in the NICU, even with the more distinct name, have a retract and reorder event. But for twins, it almost doubles to 7.9% or more than doubles. And then for triplets and high order multiples, it doubles again. So like the more siblings you have, the more errors. And for a very logical reason. We see when we look at the retract and reorder events that when you go from singletons to twins, the reason why it doubles is because there's all these errors between the siblings. So we still have our work to do. And one of the things that we're doing to try to help prevent wrong patient errors in the NICU is, I told you about the photo study. Well, we didn't think that photos of these little kids would really make that much of a difference. They're often in tubes, they look alike. And so we came up with this idea of pictographs. So we would assign a newborn baby a rainbow, and that rainbow would sort of be checked out. We had a professional, we have a grant from the NIH, a $4 million grant. Again, doing this at Presbyterian and Johns Hopkins. And the mothers can pick out an image like that rainbow for a baby. And then there's only one rainbow in the NICU. We have 80 NICU beds at Columbia. There'd only be one rainbow at a time. We have over 400 images that were drawn by an artist. So we have plenty for the parents to choose from. And then the nurses will get to know the difference between the robot and the rainbow and the purple dinosaur, and know, like, if there are triplets and they're all basically have the same name, they'll kind of learn the distinction between these images, and maybe the rainbow is the real sort of sick one. So I don't know yet if it works, or hopefully it works. The general idea is that we believe visual cues can really help improve patient identification. You could be on the wrong patient, and without a photo or pictograph, you have to rely on the words, the name. And it's hard to pick up a difference in a name on the top of an EHR, but you can notice out of the corner of your eye, if you think you're on the rainbow, you're a little sick boy, and it's a purple dinosaur, that you might catch. So it's the same study in EPIC in the little circle there and in the main pop-up. We even plan on putting it on breast milk bottles. We had a wrong breast milk error where a nurse, we barcode before we give breast milk. And so a nurse brought a couple of bottles over, put them on the counter, and a mom just grabbed one when the nurse wasn't looking to give to her baby and grabbed the wrong one. But the mom herself might notice, if she's expecting crayons and she sees a purple rabbit. Visual cues, that's the idea. Basically, our goal is to help provide the research for visual cues from birth to death with pictographs for the newborns and then transitioning to photos. Before we started the study, we were just doing a pilot to help get the grant. And Columbia, where I work, they hadn't had quintuplets in over 20 years, but this mom was due. She didn't have them yet, and she was due. So I worked with the chief of OB. The chief operating officer of the Children's Hospital said, Jason, I know you do this wrong patient error stuff, and we're expecting quints. What can you do? So the medical director of the labor and delivery and I met with the mom, and we asked her if, first of all, if she had the names ready to go. And she did. She had all the names picked out. You could see them there. This is in the New York Post. This happened to happen right before Mother's Day. So the New York Post made an article about this. And you could see Sebastian, Sophia, Mateus. Those were the names from the day they were born. And you could see on the little onesies, even though we weren't ready, we had some pictographs made and we uploaded them. She picked them. And then we had onesies made just for the fun of it. And I'm proud to say that there were 0 wrong patient errors, 0 retract-and-reorder events for the quints. You could see, if you could see that little picture below the quints there, there's a picture of like the bassinet. It says Sebastian, and there's a picture of his baseball there. And that was also in the electronic health record. When anybody placed orders for Sebastian, they'd see the baseball. We annoyed the pediatricians a bit because when she was going to deliver, you can imagine there were 5 neonatologists ready, each one assigned to a different team to take care of a different baby. Each baby had a team, a neonatologist, a respiratory therapist, a nurse. So until I got involved, it was just like team 1, team 2, team 3, team 4, and team 5. And it became team Sebastian, team Sophia, team Mateus, and they were worried about order and all, but it all worked out. Everything worked beautifully. So I put in another grant. I was so excited with this work that we're doing with wrong patient errors. I realized that I think we could expand and make more of these measures, that this general concept of how the wrong patient retract-and-reorder measure works can be extended to other types of errors. So if you see here, it's a schematic of all those blue dots are orders. And think about a provider who places an order and within a few minutes cancels that order. Why would they do that? If they're not going home or they're not going to the operating room, why would you place an order and then cancel it a few minutes error? I was thinking, well, likely it's an error. And if you see what they do next, maybe you can figure out the type of error. So if you order a couple of things on a patient, cancel them, and then the same doctor orders the exact same thing on another patient, that's the wrong patient retract-and-reorder measure. But what if I order for Mrs. A drug at a certain dose, and then 5 minutes later, I cancel the order, and then I place the exact same drug back on the exact same patient, but I change the dose. Perhaps that would be a wrong dose error. Or I do the same thing, but I change the route or the frequency. So that was the idea, and I got a $1 million grant to make and validate these measures. And it turns out at New York Presbyterian, in 1 year, there's 21 million orders. 385,000 are canceled within 30 minutes. And 112,000 are reordered back on the patient with some element changed. If you see the line for medications, about 5 million of the 21 million are medication orders. 200, but a lot of the cancellations are meds, 259,000, and 85,000 are reordered. And so look at that number there, the 85,567. That's 85,000 orders that are retracted and reordered where some element of the medication order is changed. That same number is the bottom there, if you see in the total. But this is how they're broken down. 20,000 orders are retracted and the dose is changed. 12,000, the frequency is changed, meaning change it from once a day to twice a day or 3 times a day. 5,000, the route is changed from oral to IV. And then 400, the duration, and 4,000 wrong patient. 41,000, we don't know, or it's combination. Sometimes people change multiple things. So our target was wrong dose, wrong route, wrong frequency. And here we made a bunch of calls. 272 wrong dose calls, and the positive predictive value was 76%, exactly the same that we had for wrong patient. We made 151 wrong frequency calls, positive predictive value 86%, meaning 86% of the people we called said, yep, wrong frequency, and 86% of wrong route. So our theory was right, and now we have these additional automated measures. We're just sort of finishing writing this, the analysis and getting ready to write them up. And if you look at the wrong dose measure, the leftmost column, this is so new that it's still like the output from the statistical software. And so you could see like the 1.25 is when they change the dose by 25%, 1.5, 50%. 2 is they double it. And so 2,700 there is 25%. When you look at the double it, it's 9,000. Tenfold, which could be a decimal point error, is 563. Look at 1,000-fold, 224 times. Somebody placed an order 1,000 times what, or I should say they placed an order, they canceled it, and they reduced it by 1,000-fold. So there's some scary errors in here that were thankfully self-caught. So finally, as I mentioned with the wrong patient error, when we figured out that it wasn't juxtaposition errors that was the problem, it was interruptions. So we wanted to understand, well, what are the reasons for all these other errors? Now that we're talking to people half hour or 45 minutes after they make an error, we can ask them why, what happened? And so we use this like framework that's basically based on James Reason's work and Rasmussen. And at the highest level, I like this very much. There's mistakes and skill-based errors. And mistakes are planning errors, like you plan the wrong thing. So you're going in, like let's say it's a first-year medicine intern, and he's planning to order the wrong dose. Like he's got the wrong dose in his brain. A skill-based error is he's got the right dose in his brain, but something happens, like he makes a decimal point error or something happens along the way. And you can further break down these categories, like the mistakes when you have the wrong dose in your head. That could be because you have a knowledge deficit, like a new resident just doesn't know the right way to dose a medication. Or it could be a rule-based error, like a rule is check the kidney function by looking at the creatinine, because if it's elevated, you may have to adjust it. So there's certain rules they have to follow. So you may have the wrong drug in your mind because you didn't know any better or you didn't follow a certain rule. And then the skill-based errors can be due to slips and lapses and the things we sort of all know about. So this is for the wrong patient. And so this is what I really find fascinating. If you see, in this case, we redid the wrong patient error measure in a different EHR, and we have 189 events, and 97.4% were execution errors, meaning almost always people knew the right patient, but they wound up on the wrong patient, not because they didn't know who they want, but because they got interrupted or something else. That was 97%. Now, the wrong dose is the opposite. 73%, they were planning the wrong thing to begin with. And then you can break that down, 25% of those, it was a straight old knowledge error, and 75% they didn't follow a rule, checking creatinine. But to me, it's fascinating that most of my research career, I've been working with this wrong patient error measure. But now that I think of the new ones, wrong dose is the most significant. Such a big deal because people make dosing errors because for children, babies can weigh kids can weigh 5 pounds to 500 pounds from a little kid to a teenager. There's all this weight-based dosing. So pediatricians make errors all the time. And then there's also the renal adjustment. So, and there's a lot of them, 20,000. And I told you some of them are 1,000-fold increase. And the fact that like 75% pretty much are planning errors, that's very different than wrong patient, that's execution errors. So I have all these errors in this database. We're putting together a 5-year database of errors. So I told you there are like 20,000 wrong dose errors. I'm gonna have 100,000 errors in my database, days, nights, ED, labor and delivery, and another, 20,000, 30,000 wrong patient errors. And because the mechanism is so different, I can ask you all, I don't know the answer yet, but soon I'll be able to. When you're tired, are you more likely to make an execution error or a planning error? Well, we can look at the difference between wrong patient errors and wrong dose errors and let you know. Or if you look at a service run by residents versus one by physician assistants, is one service going to make more errors than the other? And is it going to be more planning or execution? I can't wait to do these analyses. I find all this fascinating. So in summary, wrong patient errors are common. There are multiple interventions that can prevent these errors. Automated measures of errors help us understand the root causes because we can call people and interview them real quickly, shortly after they make an error. And it gives us enough power to test interventions. Without these measures, I couldn't do these studies. And I believe additional automated measures can be developed to explore other health IT safety issues. So that's it. I'm happy to take questions.
Oh, thank you so much, Jason. That was fascinating. You're a good storyteller and love your passion. Oh, and there's been a lot of activity on the chat, which you haven't noticed because you've been concentrating. So, but I'm going to start with my, host prerogative and ask the meta question, which is really about this blending of operations and research. And how do you do that? How do you create these studies that you do that get preliminary results for grants, within the hospital without research funding?
Well, what I love about balancing operations and research is that they both inform the other. So like if you're trying to get a grant, you want to do a research project that is significant and innovative. And the best way to find a significant problem is by having operations role and seeing them. And so when like a patient gets hurt from an error, the first thing we do is try to figure out what's everybody else doing, and maybe we're just missing something. And when you find that like there is no great solution, yet it's a significant problem, then there's an opportunity for research. And if you can be creative and so it's like this, exactly what happened with a lot of the research you heard today. And so we need to fix these, but we don't want more patients to get these errors happening. That's my job as the patient safety officer, is to, when errors are reported, to do root cause analyses, try to understand why they happen, and then put in solutions. I just, try to use rigorous methods to evaluate them so we really know the, if our interventions work. And I guess that's it. And then, that's how it started. And nowadays, I get more funding, and sometimes I just have straight old research questions. But I still, I have funding for a patient safety research fellowship. And so I have a lot of fellows that work on smaller projects, or sort of like where I was 15 years ago, where they're doing unfunded stuff based on real issues. And we have EPIC at New York Presbyterian. And so we're randomizing with alerts to try to improve sepsis and other sort of things.
Yeah, thank you. Thanks.
Sure.
All right, I'm gonna switch between people who have their hands raised and questions that are on the chat. So we're gonna start with Raj, who has his hand raised.
Yeah, hi. Well, hi, Jason. Thanks for your presentation. I find all of your work really fascinating. I'd actually been in touch with you about 18 months ago. I'm a doctor in Sydney, and I ran your retract and reorder measure on two of our facilities in Sydney, and I'm pretty close to publishing that now. We found pretty similar rates we had checked between 2 and 4 charts open and found similar results with no difference between the ordering errors. And look, I just wanted to, I wanted to ask about your development of the measure, because I know we'd spoken about you've gone from ordering events to ordering sessions. And I just wanted to know, well, A, if you had any updates on that. And then again, look, the work you just showed, I'm really excited to look at these wrong medication orders in terms of the doses and frequencies. That's really fantastic. I can't wait to read that.
Yeah. So your first question. So thank you for asking that question, because I neglected to talk about it, and it's a good point. We sometimes look at individual orders and we sometimes look at order sessions. And what's the difference? Very often, a provider will sit down to the computer and place a couple orders at once. I think this patient may have pneumonia. Let me order a chest x-ray and start the antibiotics now. So I order both the chest x-ray and the antibiotics, and let me also do a blood test to see if the white count went up. So I order those 3 things, but I'm on the wrong patient. And so all 3 things are on the wrong patient, and I'm on the wrong patient and I don't know it. So I could order 3 things, 5 things, 7 things. It doesn't matter, because in my mind, I'm on the right patient. And so in evaluating the effectiveness of an intervention, if you bundle all those things in the order session, so all those things were ordered together, we can call it one order session. And we decided that order sessions are a better measure to test the effectiveness of an intervention, because it may just be by chance if it happens to be 3 orders or 5 orders. If you do it at the order level, then it's 3 wrong patient errors versus 5. When you do it at the order session, each one is 1 order session. But sometimes we also describe things at the order level because we think that's just a more impactful way of describing. Like when I tell you there were 7,000 orders placed on the wrong patient, that resonates with people. Like that's just, each one is, if I order methadone and Tylenol on the wrong patient, methadone will kill you and Tylenol will be no big deal. And it's the individual orders that make a difference. So just depending on the context and what the point is, we sort of switch back and forth. But usually when looking at interventions, I use order sessions. And this, when I first published my first paper on the wrong patient measure, I got many emails about, hey, how can I recreate your measure? And I made a form and I would email it. So we're gonna, hopefully in the next few months, you'll see a bunch of papers come out about wrong dose, wrong route, wrong frequency. And my intention is to have as an appendix, very detailed description of exactly how to replicate it. So everyone's welcome to contact me, but you could just go right to the appendix and copy it. We're going to be as careful as we can to make the instructions as clear as possible.
Thanks. Kate Resenbrink, would you like to ask your question? Because you had several comments and questions on the chat.
Oh, yeah, thanks. Just excellent. Makes my heart sing to hear about this work, Jason. And you know, for 25 years, I've been wanting to make things different and better. And I'm in the role of Chief Nursing and Midwifery Information Officer. And I know that organisations really have these sort of old traditional structures. We've got a big quality and safety team, but that's not where the improvement and change is happening in that iterative space. So I'm just wondering, yeah, where would a big organisation start? What could we do that is small that could grow and scale? And which new roles do we need to, I guess, to challenge the old way of, you know, waiting for people to report, investigating, and coming back with outcomes 3 months later, which just don't have any relevance?
Yeah, thank you. That's a great question. There was an article in the New England Journal 2 years ago. Oh, I'm sorry. I'm trying to think of the name of the author. It'll come to me in a second. She's an NYU researcher. oh, it'll come to me in a minute. But anyway, she wrote about learning health system and the value of doing rapid cycle randomized improvement, not for grants, but to honestly know if you're making a difference and if your intervention works. Leora Horowitz is her name, 2019 New England Journal, Leora Horowitz, Learning Health System by Rapid Cycle. And so some of it was they have Epic at NYU and they do random BPAs, like does an alert to remind providers to tell their patients to stop smoking make a difference. And interestingly, many of the studies that they share in this paper were interventions that they already had in place, but they questioned if they were effective and if they're really just wasting their time and annoying people, including not all of it was EHR. Some of it was like, we call patients after they've been discharged home to help prevent readmission, make sure they got their meds. And even that wasn't so effective. And they didn't abandon the idea of post-discharge phone calls, but they changed their script. And so, but they did studies, some of them were, all you need to do is randomize for 2 weeks or a month. Like the studies I share with you, some of these that I'm doing as NIH grants are 2-3 year studies, but I'm doing more and more rapid cycle quality improvement. And so we make decisions to help ensure it's rapid cycle. So for example, if you wanted to try an intervention to to prevent urinary catheter infections, CAUTIs, you could randomize and do an intervention that where the outcome is CAUTIs themselves, these infections. A study like that might take 3 years because CAUTIs are rare enough. But if you just look to see, does it decrease how long the urinary catheter is in place, you may be able to make an informed decision in a matter of 2 or 3 months instead of 2 or 3 years. Because we all know that urinary catheters that are in for 7 days has more of a chance than 3 days of having an infection. So we pick sort of process measures instead of outcome measures that we really believe in and informed. But because when you do these before or after studies, and if you have a problem like urinary tract infections, CAUTIs in your hospital, and it's a big deal and everybody's worried about it, and we're trying 10 different interventions and suddenly they go down, but you don't know which one helped because everybody was just throwing everything they could at the problem. And so, that's sort of where I've been pushing lately, and we've been doing these rapid cycle following Leora's Horowitz.
Yeah. Oh, sorry. Go ahead.
No, I think you would ask, like, what kind of people do we need? I don't know. I think lots of people can do it. It may be more of a mindset than, meaning like, as long as you're leading a quality improvement initiative, I would just communicate the value of a learning health system and the power of randomization, even for quality improvement. Sorry, Wendy.
No, thank you. Daniel?
Yes, thank you, Jason. This is a great talk. I'm just curious about what are you thinking about implementing the patient photos? So in my previous life, I was Chief Medical Information Officer, and we rolled out an EMR that by default came with patient photos. And the problem we ran into is, like, when do you take these pictures? Half of our patients came in through the ED, and that's not the best moment to take pictures. So we spend many months without having the pictures there, and then patients started complaining that they didn't like the picture. So we ran into so many implementation problems. I don't know. I'm just curious about what are your thoughts around that?
Yeah, I have this big grant to study if photos can prevent wrong patient errors, randomizing whether providers can see them or not, using my retract and reorder measure as an outcome. But I'm struggling with that exact problem. Like, we need photos in the EHR, and how do you get them, and when do you take them? And there's a lot of obstacles. And also, we're relatively new on Epic. The EHR we had before that was old scripts. Epic has these like kiosks. It's a lot of self-serving, like you just go up to like an iPad that's against the wall and to register when you come in. It's no longer like standing in front of a human where they can say, all right, we want to take your photo now, and smile. You go to an iPad and you say, is that your insurance? Yes. Is that your address? And the iPads have the power to say, okay, smile. And then you take a picture, but there's no human to like coach you through it. Or And so some places at Neuropresbyterian still have the human there taking pictures. Some have the kiosks. And then, you know, there's a real issue. We just published a paper using the retract-and-reorder measure showing that we compared labor and delivery where women have babies compared to women of childbearing age in the hospital, and showed that wrong patient errors on labor and delivery are double that of the same age women on the floors. And so now labor and delivery really wants to do this photo project, but that's a whole other thing. How do you take a photo of a woman who's coming in active labor, and patients who come in the ER by ambulance, or a 2-year-old who's squirming, like, so you put them on the mom's lap and you try to zoom in only on the kid, but what if they're registering through the kiosk? So I don't have I suspect that our analysis is going to be more instead of per protocol, like an as treated, like of the 40% of the patients we got photos, wrong patient errors were reduced by X, Y, and Z. And we're going to spend some time like figuring out how to optimize taking the photos. And then the next question is, how often do I retake them? As you said, patients don't like them. That's another thing. In Epic, lots of people have an app and they can take them themselves on their iPhone and upload it. So there's a lot of work to do here. I think right now we're just focusing on, do they prevent errors, and how, you know, is it 20% or 50%? Like, what exactly is the effect?
Thank you.
Yeah, thanks. So I note that our time is almost up. Are you okay, Jason, to stay on for a few minutes to answer more questions?
I am. I can stay as long as you need me.
Excellent. And then we'll let those of you who have your next Zoom meeting to attend, because Jason, we're still in lockdown here. Well, yes, I would say still. We're in our 6th lockdown here in Melbourne. So we've all, anyway, we are all full of Zoom meetings. But let me ask, oh, I forgot. Irene Jablanca had a couple of questions on the chat. Are you still on, Irene? Okay, then I'm going to go to Phil, who has his hand up.
Thanks, Wendy. I can see Irene's name anyway. Jason, great. You've, like Kate, as a very former pharmacist in health IT for the last 35 years, this is really fantastic stuff. I put in the chat, and I'm happy to email it to you, a case we had here in Australia, whereby, and it was in the OR, and your chart showed different places within the hospital and the measure between them, and emergency and outpatients, etc. This was where an anaesthetist had a patient on the table in front of them and had forgotten to order post-op for the person who just left to recovery. So switched to that patient, so one patient at a time, but forgot to switch back. And so ordered for that patient in the recovery a whole bunch of extra stuff for the young woman. And this is a 60-year-old man who subsequently died, and very unfortunately. So have you seen that sort of issue where, so it's switching and not switching back type issues, whether it's how many patients you can have open at once or not, and what your experiences is with OR and anesthetics? Yeah.
Yes, that's one of the major mechanisms that we see of why people place orders on the wrong patient. And as far as the OR and anesthetics, I haven't actually looked at that question. I'm certain it seems to be everywhere, these issues. And it's one of the things that excites me. I have a lot of students and fellows that I work with, and I think I mentioned I'm making a 5-year database of like all of these errors, wrong dose, wrong route, wrong patient. And I tell the students and fellows that I'm pretty confident that we can look at subsets. Like you just said, you asked an interesting question. How often do anesthesiologists place orders on the wrong patient in the operating room? And we have so many, or wrong dose errors for that matter. And we can look at that. And that's sort of where I'm heading, that how often does an ophthalmologist, you know, have medication errors with their very specific kind of eye drops, wrong dose, wrong patient. And I tell the residents, if there's any medical student who wants to be an ophthalmologist, you know, take on that question and publish on it. There seems to be a lot of interest in this like area of research. So most of the journals are very excited by us submitting papers. So I hope once I have my database set up to attack a lot of these questions. I don't know that at the moment how big a problem it is.
Thank you.
Graham.
Yes, thanks, Jason. Graham Hart, I'm an intensive care specialist until recently, and now I'm in CMIO at the Austin. One of the things that we did when we first put in the Cerner system as a statewide implementation 15 years ago was consciously elect to only have one chart open at the time to try to avoid these wrong patient errors. You've now shown that it makes no difference whatever. Should we change back? What are the other potential risks, benefits, or otherwise, or efficiency gains of having multiple charts open compared to just one? Did you find anything at all that would say we should change if it makes no difference for meds errors?
Yeah, well, I could tell you that my study was the first randomized trial, and I'll answer your question, but I worked with some colleagues who had Cerner, and this is, I think, similar to, was it Raj who was saying before, they went, you can find this paper. If you see my JAMA paper, I reference it. In a Cerner system, they went, I think, from 4 to 2 and used my measure, and so saw no change either. My randomized trial was an EPIC, and I don't know what Raj, and he's doing the same thing, going from 4 to 2, if that also is Cerner. Raj, is that Cerner?
Correct. So I think the paper you're referencing was in the ED, and that was also Cerner, and yeah, we replicated it in Cerner as well.
So the, between that paper and what Raj has done, to me, it's all reaffirming like our paper. We published another paper in JAMA Internal Medicine when we had the folks randomized to 1 versus 4 in the health system. We took the opportunity while they were randomized to survey them and ask them a bunch of questions about efficiency and benefits to try to get at your question. And the user satisfaction was much higher for the group that had 4 compared to 1. But I think there's a large bias there because if you took 2 hospitals on Cerner, let's say, one in New York and one in Sydney, and one was on 4 and one was on 1, and you did a survey, the difference I don't think would be nearly as dramatic as when you randomize people in the same hospital and the people have been sitting restricted to 1 and the guy right next to him had 4. Like, I think they were just pissed off and they let us know via the survey. So I think the difference was, more dramatic because of that. So there was a difference, but I'm concerned about that bias. But then we didn't publish this yet, but we're working on this now. We looked at how much time people spend on the EHR, those that were in the 1 group and those that are in the 4 group. And Epic has this cool measure of every time you touch a key or move a mouse or do anything, a clock starts. And when you sit idle for 30 seconds, it stops, and it adds up the total amount of time in the day. So it's a pretty good reflection of how much time you spend in the EHR. And there was no meaningful difference amount of time people spend in the 2 groups. So, and that's all I know. I know that there's no real difference in time clicks between the 2 groups. I know that the users in 4, in the middle of the randomized study, said they liked it a lot better, and that's published, you can find it. But I confess that bias. I think it's there, but it's just dramatized. So, but I think it's safe to allow multiple records open for the reasons I said, and evidence seems to suggest that people prefer it and find it to be more efficient. Although the time is the same, the quantitative measure, there is no difference. It's not more efficient, it's not more dangerous, it's just kind of the same. But
all right. Well, thank you so much, Jason. Thanks for staying late with us and for the excellent talk and the good discussion afterwards. We really appreciate your time tonight.
Yes, my great pleasure.
All right. Thank you everyone for joining. Our next seminar will be in 2 weeks. And it's going to be Anna Peters from Deakin University talking about transformation of health.